by the incoming president of the organization. There was one deviation from that directive last year when Alan Whipple, in a miracle of modern technology, graced us with his insights in New Orleans. There are only a handful of people in this organization that could pull off establishing yet another named lectures. There's a lot, but Dave Feliciano and Grace Rozycki comprise 40% of that influential group because of the high regard in which they are held and their years of dedicated service and support of the organization and this meeting. This year's lecturer and incoming president is Dr. Timothy Farrell, who has similarly served this organization faithfully and tirelessly. Tim is the immediate past executive director of the Southeastern Surgical, where he literally brought the organization into the modern era. It was his idea to introduce the meeting app, which all of you have on your phones today. He shepherded out the old paper posters and introduced the electronic quick shot format, and is the backbone, which is the backbone of our meeting. And perhaps most importantly, he guided the organization as it made the transition to professional management. I believe that Tim and Ken Sharp are the only two members of the Southeastern Surgical Congress who've been to the inner sanctum of the Southeast Surgical, the storage facility in Cummings, Georgia. Tim's impact on the Southeast Surgical will be felt for years to come, and there's no one in this room more deserving to stand before you and deliver this lecture than him. As I said just a few moments ago, I consider Tim one of my dearest friendships arising from this society. This morning, Tim's going to talk about the evolution of the M&M Conference in Surgery from Codman to contemporary practice. Congratulations, Tim, on your well-deserved selection as incoming president of the Southeastern Surgery.
It's hard to follow what Manny did with this a year ago. That was Manny, I think. But thank you so much, Dr. Zerbos. This is the Feliciano Rozycki lecture. Today we'll explore how one of the most defining traditions in surgery, the M&M Conference, evolved from a radical idea in the early 1900s to a cornerstone of modern surgical education and patient safety. And as you heard, this lecture is named in honor of two leaders in surgery. Past President Dr. David Feliciano was a pioneering trauma and acute care surgeon, known for his technical mastery and decades of contributions to trauma care. He was a strong advocate for rigorous M&M as a teaching tool. And past President Dr. Grace Rozycki, who is a distinguished trauma and critical care surgeon, also a noted educator and leader in surgical training. She has advocated for structured, fair, and educational M&M practices. Their careers exemplify the principles of accountability, teaching, and patient safety that the M&M Conference represents. So I have no relevant disclosures. So we'll start by tracing the historical development of M&M, how it emerged organically from early efforts at hospital standardization and professional accountability. Then we'll highlight key contributors who shaped the M&M Conference over time: Ernest Codman, Franklin Martin and the American College of Surgeons, Charles Bosk, the ACGME, Lucien Leap, the Institute of Medicine, and finally the ACS NISQIP initiative, which represents a more data-driven, systems-focused era. Additionally, we'll examine the structural shift in M&M from assigning individual blame to emphasizing systems learning, and patient safety science. Finally, we'll discuss modern surgical practice, modern practice, including the challenges posed by technology, medical legal concerns, and the ongoing effort to preserve M&M's educational core amid increasing complexity. So at the turn of the 20th century, hospitals transformed from charitable refuges into structured centers for clinical care and education. This created the foundation for systematic review of patient outcomes. Committees began examining deaths and complications, and these were primitive but groundbreaking attempts at organized quality review. The driving force behind this shift was Dr. Ernest Armory Codman of Boston, Massachusetts. Dr. Codman's end result system tracked every patient from diagnosis through outcome, documenting treatment plans, complications, and final diagnoses. His colleagues opposed him, leading to professional isolation, but his ideas later inspired the college's hospital standardization program in 1918, which was a precursor to modern QI initiatives. So Codman was at MGH. He proposed following every patient until the final end result was known. Most controversially, Codman advocated for public reporting of results, arguing that openness was essential for progress.
After leaving Mass General, it was hard to be rejected by my peers. They felt my end result idea threatened reputations and livelihoods. Still, I held firm. Every patient must be followed long enough to know whether care truly helped or harmed. Without honest results, medicine cannot improve.
So despite being shunned, his ideas anticipated modern QI efforts and laid the foundation for M&M. Franklin Martin founded the American College of Surgeons in 1913, seeking to standardize surgical practice. In 1918, as I mentioned, the college launched the Hospital Standardization Program. Requirements included keeping accurate medical records and conducting mortality reviews.
Progress in surgery comes from confronting results, not protecting reputations. That is why I created the American College of Surgeons to raise standards and ensure our profession governs itself. Ernest Codman shares this belief, insisting we track outcomes and openly examine errors. Honesty is the path to trust and improvement.
This formalized Codman's once rejected vision. Accountability became institutional. Over time, this framework has contributed to the evolution of the structured M&M conference. M&M became a routine forum in academic surgery. The style was often harsh and intimidating. Residents presented cases and senior surgeons critiqued. The focus was primarily on individual mistakes in judgment or technical errors. It reinforced a hierarchy. Attendings set the tone, trainees absorbed the culture. Little emphasis was placed on systemic or multidisciplinary issues, and despite its flaws, M&M was deeply educational and shaped surgical identity. So let's imagine the learning environment of the time. Take the case of a 54-year-old man who had a sigmoid colectomy. He develops early signs, tachycardia, abdominal distension, and a rising weight count. The intern voices concern, but is dismissed by the more senior surgeons. Imaging is delayed, and the patient develops sepsis from an anastomotic leak. During M&M, the faculty blames resident judgment. It's a hierarchical, blame-focused culture that does not seek systems change. The growth of M&M Conference also has roots in Philadelphia, much like Rocky. In 1935, the Philadelphia County Medical Society created an anesthesia mortality committee to review deaths related to anesthesia. By 1940, this evolved into the Anesthesia Study Commission, which held monthly meetings that included surgeons fostering collaboration. The meetings served a dual purpose, educating providers and improving systemic practices to prevent errors. To encourage honest reporting and open discussion, providers' identities were actually kept anonymous. Charles Bosk was a sociologist who studied surgical training in the 1970s. He observed rounds, operations, and M&M conferences. He interviewed surgeons and nurses and reviewed case records and mortality data. The focus of his work was to determine how surgeons understand, classify, and respond to mistakes.
In Forgive and Remember, I embedded myself with surgical teams to study how mistakes were assessed. Technical errors involve skill, judgment errors involve decisions, and normative errors involve professional lapses. The responses from surgical leaders affected careers and defined the local culture within the department.
Core findings were that technical and judgment errors were often forgiven if admitted and fixed. Normative errors were unforgivable. These included dishonesty, irresponsibility, and arrogance. M&M functioned not just as a venue for education, but also as a tool for enforcing this hierarchy and professional norms. In 1979, Bosk published Forgive and Remember. He emphasized that a culture of blame prevents teams from learning from mistakes. He argued for a shift toward acknowledging failures without assigning personal blame. This approach encourages collaboration among surgeons, enhances education during M&Ms, and ultimately improves patient care. By the 1980s, the educational value of M&M was clear, leading the ACGME to require standardized weekly conferences as a condition for residency accreditation. The ACGME mandate of 1983 made structured review of adverse events and mortality a national expectation. This standardization reframed M&M as a shared educational framework built around three principles: education, reflection, and accountability. The intent was not blame, but thoughtful self-assessment, professionalism, and system-level learning. In this way, M&M continued to evolve from a local tradition into a foundational tool for training surgeons to improve care. Now, you may have heard the claim that medicine has a 30% error rate, a figure often associated with Dr. Lucien Leap. That idea comes from surgical science. In his 1991 Harvard Medical Practice Study, Leap found that about 3.7% of hospitalizations involved adverse events, and nearly a third were linked to negligence. At the same time, trauma and surgical series routinely reported complication rates around 30%, even at high-performing hospitals. Leap used these data to make a larger point. Errors and complications are common and systemic, not evidence of bad doctors. Real improvement comes from acknowledging them, understanding their causes, and redesigning systems rather than assigning blame. In Leap's 1994 JAMA article, article marked a major turning point in the patient safety movement. By drawing parallels to aviation and other high reliability industries, he emphasized the need to understand human limitations and build safeguards into processes.
In our 1994 article, we argued that most medical errors came from flawed systems, not bad people. A culture of blame silenced learning. By applying systems thinking and human factors, we showed how safer care could be designed. Our work later influenced the Institute of Medicine's To Err is Human report.
So Leap is credited for introducing systems thinking and human factors as the keys to preventing harm in medicine. Based on data from Dr. Leap and others, in 1991, the Institute of Medicine published a landmark report, To Err is Human, which shocked the public and the profession. It estimated that between 44,000 and 98,000 Americans died each year from medical errors. It framed medical error as a public health crisis and catalyzed the patient safety movement. It also more broadly reframed error as a system problem, not an individual problem. It called for national reporting of errors, investment in safety infrastructure, and stronger leadership in patient safety. For M&M, it was a turning point, a call to go away from blaming individuals towards analyzing systems and preventing harm. After 1999, M&Ms began to change in tone and structure. Non-punitive approaches became emphasized. The goal was learning, not shaming. Structured analysis tools were adopted: root cause analysis, fishbone diagrams, S-bars, and other communications frameworks. Hospitals invested more in quality and safety departments. M&Ms became more multidisciplinary, with nurses and anesthesiologists and administrators often included. The culture shifted closer to safety science. In 2016, the ACGME released its first CLEAR report to see how the core competencies were showing up in residency training. While most surgical trainees understood these competencies and valued patient safety, their everyday experience often didn't match the ACGME priorities. This report exposed major gaps, with over 80% of residents having limited knowledge of patient safety principles and fewer than half having had taken part in a multidisciplinary safety review. In response, some programs reshaped M&M conference to focus more on adverse events and safety failures, closer to the IOM's original vision. Even so, beyond the original mandate in 1983, the ACGME still offers little specific guidance on how surgical M&M conferences should be structured. Despite the lack of safety mandates, most current M&M conferences have become more structured and system-focused. Case selection and presentations are more standardized, keeping discussions consistent and data-driven. Departments often use tools like root cause analysis and fishbone diagrams to identify process, communication, and system contributors beyond technical error. Another key evolution is broader participation. Adding a multidisciplinary perspective allows review of the full perioperative systems, from surgery, anesthesia, nursing, and even support services. This shifts M&M from individual blame towards shared accountability and actionable patient safety and quality improvement. In 2001, the college launched NSQIP to track surgical outcomes and enable risk-adjusted benchmarking across hospitals. NSQIP can be used to reshape M&M conferences by guiding case selection and shifting discussion from anecdotes to data. In fact, in 2006, Dr. Hutter and colleagues showed that NISQIP identifies nearly twice as many complications as traditional methods for M&M case selection, underscoring the limits of voluntary reporting and the value of having objective data. So this slide shows how the ACS turns quality review into system-level improvement. At the center, the college provides the infrastructure for surgeon-led safety work. Planning tools such as the quality framework, early project design resources, and case study repository help teams assess performance, define achievable aims, and avoid poorly designed improvement efforts. Educational tools such as the ACS quality courses, micro-learning videos, and quality grand rounds build the skills needed to do QI well. Implementation tools such as Strong for Surgery translate ideas into safer care, and shared learning and standards such as NISQIP benchmarking and the ACS standards manuals allow improvement to spread and be sustained. Together, these resources can turn M&M from discussion into continuous improvement. Let's talk a bit about the cultural barriers to reporting complications. Surgery has long been shaped by an unspoken expectation of perfection, that we're not supposed to make mistakes. That mindset creates emotional burden, discourages people from speaking up, and costs us for valuable learning. It's reinforced by hierarchy, patient expectations, and medical legal pressures. But safety science tells us error is inevitable in complex systems. So the shift has to be from perfection to reflection, learning instead of blaming. M&M conferences work best when honest case review is paired with psychological safety. Errors are common in healthcare, and even small ones add up and affect patient safety. As care becomes more complex with new procedures, technologies, and medications, the opportunities for error increase. At the same time, a culture of infallibility discourages disclosure, leading to underreporting and blame. Together, this creates an error-enabling environment. Errors are likely, but are poorly managed. The solution is shifting from individual blame to systems-based prevention that anticipates human fallibility. After To Err is Human highlighted the scale of preventable harm, the Institute of Medicine's next report shifted the focus. Rather than just counting errors, Crossing the Quality Chasm emphasized redesigning care systems to prevent them. It defined 6 aims for high-quality care: safe, effective, patient-centered, timely, efficient, and equitable. The key message was that safety is a property of systems, not individual vigilance. To achieve that, the report emphasized standardization, teamwork, and continuous learning as core strategies for safer care. Atul Gawande helped make patient safety real for clinicians. In Complications, he showed that most mistakes come from the complexity of medicine, not bad doctors.
There's a favorite essay I have about the nature of human fallibility, and it points out that there are at least 2 reasons why human beings fail when we set out to do anything, and one reason is just plain ignorance. A doctor can fail because the knowledge doesn't yet exist about how to take care of Alzheimer's disease or what the nature of it really is. Another reason we can fail, however, is ineptitude, as the philosophers put it, meaning that the knowledge exists, but an individual or a group of individuals fail to apply it correctly. We struggle in our generation now with both being huge issues for us. And that's very different from past generations. For millennia, ignorance was the central governing factor in the course of a human being's life. We didn't understand disease and we didn't understand what we could do about it. But that's changed. And now we have reason to fear that we may not be getting the knowledge that exists, that mistakes may be made. But then there's a third reason that doctors can fail, and that's hubris. That is, we may fail because we don't understand that we will always have areas of ignorance, that there's necessary fallibility no matter how much science advances.
Then in the checklist manifesto, he flipped to solutions, simple tools like checklists and timeouts that make it easier to do the right thing. Along with the Institute of Medicine, this helped move M&M conferences away from blame and towards fixing the systems behind the errors. So if you doubt that systems changes can improve patient safety, just think about trauma systems. where regionalization and structured protocols have clearly reduced mortality. When there's no system, preventable deaths are significantly high. With improved triage implemented through statewide trauma systems, mortality falls by about 8%. Direct transport to trauma centers produces additional reductions by avoiding delays in secondary transfers. The largest gains are seen in trauma systems where coordinated teams, standardized protocols, and definitive care are associated with a 15 to 25% lower mortality overall, and about a 25% reduction for the most severely injured patients. Importantly, these improvements are not static. Ongoing quality improvement and iterative systems redesign continue to drive further safety gains over time. One of the reasons trauma systems work is that they force us to rethink what we mean by error and preventability. As we have mentioned, over time, the focus is from shifting the blaming of individual mistakes to identifying opportunities for system improvement. By 2011, the college's Committee on Trauma updated its definitions of preventable and possibly preventable events to better reflect the realities of clinical care. Building on that shift, McCary and Daniel stepped back and asked what this means at a population level, arguing that medical errors should be recorded on death certificates. Their analysis suggested that medical error could be the third leading cause of death in the United States. Taken together, this reinforces the lesson from trauma systems. When harm is defined, measured, and recognized as a systems issue, it becomes something we can actually improve. So M&M conferences now serve multiple purposes and have evolved into a central space for education and improvement. These conferences support patient safety by identifying errors and system gaps, and they sharpen clinical reasoning by walking through real decisions and outcomes. They also strengthen teamwork, bringing surgeons, anesthesiologists, nurses, and others into the same conversation. Just as importantly, M&M promotes professional accountability, encouraging reflection without blame. Taken together, this makes M&M a driver of continuous learning and quality improvement, focused not on just what went wrong, but on how we think, decide, and design safer systems. Despite progress, several challenges remain. A culture of blame can still limit open discussion and system-level analysis. Underreporting and selection bias persist, driven by time pressure, discomfort, and medical legal concerns. The structure and rigor of M&M vary widely across institutions. Competing clinical demands limit preparation, discussion depth, and follow-through. Finally, integration with formal quality improvement and accountability for action items remains inconsistent. The challenge is balancing education, accountability, and meaningful system change. So because the structure and focus of M&M conferences vary widely across institutions, the college's Board of Governors sought to better understand how current practices exist across the country. The board conducted national surveys of both attending surgeons and surgical trainees to assess how M&M is organized, its educational value, and its role in promoting a culture of safety. The goal was to identify best practices and opportunities to strengthen the educational and QI impact of M&M. So trainees and faculty were broadly represented across regions and hospital types. Regarding the structure, trainee attendance at M&M is typically mandatory, whereas faculty participation is more selective. Regarding educational value, M&M usually takes place as a 1-hour weekly morning conference. It's often trainee-led, but it lacks standardized structure. Both groups view M&M as educationally valuable, but point out that active faculty engagement is really essential for this outcome. The main gap is follow-through. Action items are identified, but implementation and feedback, especially to the trainees, are inconsistent. A culture of safety is widely recognized by both groups, and the key opportunities for improvement include greater interdisciplinary participation, more structure in the case formats, stronger links to quality improvement, and targeted use of technology to improve engagement and follow-up. M&Ms used to rely on memory and handwritten notes. Now we have EMRs and registries like NISQIP that can give us accurate data and meaningful benchmarks. We have dashboards, video, and simulation that can make system issues and technical learning easier. AI may soon help flag high-risk cases and near misses. Despite challenges, technology is making M&M more objective, data-driven, and focused on systems. So M&M has evolved from Codman's early outcomes tracking to a structured, data-driven process shaped by the American College of Surgeons, the ACGME, the Institute of Medicine, and NISQIP. Culturally, it's moved from individual blame to systems learning and shared accountability. Today, M&M remains both a core educational forum and an ethical responsibility in surgery. The challenge ahead is using data and technology without losing humility and empathy. The goal is continuous, transparent learning built into everyday practice, not just a weekly conference. So let's look again at that case from earlier, but through the lens of the modern M&M model. Remember the 54-year-old man with the sigmoid colectomy who developed tachycardia and a rising weight count on post-op day 1 or 2. The intern speaks up about concern for a possible leak. The attending is notified and a CT is done, which confirms an early leak. The patient is returned to the OR, has a washout and ostomy. This prevents sepsis. This case highlights how psychological safety and a flat hierarchy allow all team members to speak up and therefore protects patient safety. So I'll close with this. M&M is one of the oldest traditions in surgery because it matters. It reflects our commitment to honesty, accountability, and getting better for our patients and for each other. It's evolved from Codman's early ideas to today's data-driven, team-based discussions, but the core purpose has not changed. As current and future leaders, it's on us to protect what makes M&M work: rigor without blame, accountability with psychological safety, and conversations that actually lead to change. M&M isn't about what went wrong. It's about how we choose to learn together for the next patient. So with that, I'd like to just say I am deeply honored to deliver this lecture in the names of Dr. David Feliciano and Grace Rozycki, whose careers embody these values. Thank you very much.
Now I will reciprocate with another glass tchotchke. So.
Thank you.
Thank you, Tim. I think this brings us to the end of the morning session. We're going to break and we'll reconvene after lunch. Remind you all, there's 2 lunches today. There's the Legally Mine lunch and then the Practice Committee AI lunch. You needed to purchase a ticket for the AI lunch, and Legally Mine is free of charge. Thank you all.